All right, let's dive right into this explainer. Welcome. Today, we're unpacking a truly essential, high-retention clinical guide pulled straight from the ACCP 2022 PICU protocols. Look, if you're managing pediatric critical care patients, you already know the stakes are incredibly high. Mastering sedation and analgesia isn't just important, it's absolutely paramount.
To make sure you get the absolute most out of these guidelines, we've broken things down into 4 clear sections: core sedation and analgesia basics, adjunct medications and safety risks, critical NMB safety protocols, and finally, managing delirium and withdrawal. Let's get right to it.
Starting off with Section 1, core sedation and analgesia basics. This is the essential combination for our PICU patients. So I want you to think about this foundational question for a second. What actually constitutes the core concept of PICU sedation? Well, according to the protocols, there is no single magic bullet. The core concept really relies on a synergistic combination. You're pairing an anxiolytic with an opioid. In the vast majority of cases, you're going to see the classic midazolam plus fentanyl combo. But to use these safely, we really have to understand what each half of that combo is actually doing in the body. Now, this brings us to a massive pain management basic. There's a stark contrast between these two classes. It's a strict zero-sum game, and keeping this straight is absolutely crucial. Benzodiazepines, your midazolam, your lorazam, they provide excellent amnesia, but they provide absolutely zero analgesia. They will not touch the patient's pain at all. Contrast that with opioids like fentanyl, morphine, or hydromorphone. Those give you powerful analgesia, right? But they offer absolutely zero amnesia. You really need that combination to cover both the pain and the terrifying memory of being in a critical care environment.
But, of course, these core drugs come with some major red flags, which is where a solid clinical nursing guide comes into play. Let's look at a specific drug safety case for our benzos. For midazolam, the big watch-out is that it has a renally eliminated active metabolite. If your patient has renal impairment, that metabolite is just going to build up, leading to dangerously prolonged sedation. And then there's lorazepam. The risk here actually isn't the drug itself, it's the solvent. It contains propylene and polyethylene glycol. In high or prolonged doses, that can cause a severe anion gap metabolic acidosis. You've got to monitor for that.
Flipping over to opioids, the safety profile shifts, but the risks are just as critical. Fentanyl is incredibly fast-acting and hemodynamically stable, but if you push it too rapidly, it carries a severe risk of chest wall rigidity, literally making ventilation nearly impossible. Morphine, on the flip side, is notorious for causing histamine release. That means you might suddenly see vasodilation and a massive drop in blood pressure. You really have to know your patient's baseline hemodynamics before choosing between these two.
Moving on to Section 2, adjunct medications and safety risks. This is where we tailor our pharmacology to specific clinical needs.
Let's expand our clinical toolbox a bit. Propofol is a fantastic bridge to extubation because it clears out so quickly, but the safety parameters are incredibly rigid. You absolutely must keep it under 4 milligrams per kilogram per hour and strictly limit its use to less than 24 to 48 hours. Why? Because you want to avoid PRIS, propofol infusion syndrome, and hypertriglyceridemia, which can literally be fatal. Then we have dexmedetomidine, or DEX. It's an alpha-2 agonist, and its beauty is that it provides sedation with minimal respiratory depression. The catch? You've got to watch those cardiac monitors like a hawk for hypotension and bradycardia. When we start tailoring to a patient's exact pathophysiology, our choices get highly specific. Take ketamine, for example. It's a dissociative anesthetic, but crucially, it causes bronchodilation. That makes it a brilliant choice for a patient with severe asthma. Just remember, you need to pre-treat with a benzo to avoid those terrifying emergence phenomena. Finally, we have barbiturates. Now, these are strictly last-line therapies in modern protocols, but they do have a highly specific utility. They lower intracranial pressure, making them exceptionally useful in traumatic brain injuries.
All right, Section 3, critical NNB safety protocols. These are the high-stakes scenarios in neuromuscular blockade.
Okay, listen up. If you take only one single thing away from this entire explainer, let it be this absolute non-negotiable NMB safety protocol. Neuromuscular blockades, paralytics, provide astonishingly zero sedation and zero analgesia. They do one thing: paralyze the muscles. If you do not give sedation and analgesia first, you are literally trapping a fully conscious, feeling patient inside a paralyzed body. Sedate first. Always, no exceptions.
With that golden rule firmly established, let's walk through the actual NMB agents. Succinylcholine is a depolarizing agent, meaning it carries a massive risk for inducing hyperkalemia and triggering malignant hyperthermia. Rocuronium is your standard, trusty go-to for rapid sequence intubation. But perhaps the most important clinical note on sedation drug risk and paralytic selection here is regarding cisatracurium. Because it undergoes Hoffman elimination, meaning it spontaneously breaks down in the blood plasma, it doesn't rely on the liver or the kidneys to clear, so it is hands down your absolute best choice if your patient has renal or hepatic impairment.
Administering the NMMB is only half the job, right? The other half is strict monitoring. You must monitor the depth of the blockade using a train of 4 nerve stimulator to test muscle twitches. On top of that, you need to be hyper-vigilant about drug interactions. The blockade is dangerously potentiated, meaning it's prolonged and strengthened by some very common ICU drugs. If your patient is on aminoglycosides, beta blockers, or corticosteroids, you are going to get a much deeper, longer-lasting paralysis than you bargained for.
And that brings us to Section 4, Managing Delirium and Withdrawal. Let's look at our post-sedation treatment protocol flows.
We now face a massive clinical red flag and honestly a fascinating paradox in critical care. The very drugs we use to calm the brain initially often end up injuring it over time. Benzodiazepines, especially our core drug midazolam, are a primary key risk factor for developing ICU delirium. The protocol is crystal clear here. To protect the patient's long-term cognitive function, you must aggressively limit midazolam infusions as soon as it's clinically safe to do so. So, what's our treatment protocol flow if that delirium does occur? Well, first-line treatment is always non-pharmacologic. Bring the parents to the bedside, get that day-night sleep-wake cycle back on track, and avoid physical restraints whenever you possibly can. Only if the delirium is totally refractory do you step up to pharmacology using haloperidol or risperidone. And a huge warning here, if you use those antipsychotics, you must immediately get that patient on a monitor and watch their QTC interval closely.
Now, I want to pose a direct clinical scenario to you, to pivot into our final highly critical topic. What happens to the physiology of a pediatric patient when they've been on these continuous sedation infusions for more than 7 to 9 days? Well, at that point, the whole game changes, and the primary risk profile shifts entirely. Right at that 7 to 9 day mark, the primary risk suddenly becomes iatrogenic withdrawal. Here is the strict first-then protocol flow. Step 1. Identify the risk. If they cross that 7 to 9 day threshold, physical dependence has very likely occurred, and just abruptly stopping the meds will cause severe withdrawal syndrome. Step 2. Execute a controlled wean. The protocol dictates swapping out those short-acting infusions for longer-acting enterals. Specifically, you're going to transition the patient to a highly controlled, tapering combination of lorazepam and methadone. Wow, we have covered a tremendous amount of ground today, from the zero-sum reality of benzos and opioids to the unyielding rules of neuromuscular blockades, right through to managing withdrawal. So I want to leave you with this final thought. What exact steps will you take on your very next shift to ensure your patient's sedation protocol prioritizes safety first? Take these protocols, apply them directly to your practice, and stay sharp out there. Thanks so much for joining me on this explainer, and I'll catch you next time.